This conference will now be recorded.
Okay, excellent. So as I was saying, if you have the link to this room, the CIC study room, Review with Luz, you just have to click on that link every Friday at 2 p.m. Eastern Standard Time, and then we will be here doing what we do best, which is having fun and learning about infection prevention. The other question that I've gotten asked a lot is, where can we find the recordings? So I used to send emails out after, every meeting and send a link and all of this stuff. I apologize, but life is wild. Time management is at an all-time high here. So just know you can find it on YouTube. So I am uploading them to YouTube sometime over the weekend. You'll be able to see the recordings there. You just got to type in CIC epidemiologist. There's a whole little channel. Do my thing there, and you can find the recordings. Okay, so those are the two biggest questions that I've gotten asked this week. So I hope that is helpful. Okay, before we proceed, any questions? Any questions? Any questions? Okay, excellent. Onward then. Okay, is this working? Yes. All right, so we're going to do just a quick update, CIC study plan, chapters 21, 22, and I was able to include a bit of 23, and then next week's assignments. Okay, so for group participation, you're either able to send your message to me, the organizer, or you can send it to the whole group. You didn't hear anything? Okay, but you guys can hear me, correct?
Yes.
Okay. So organizers, you can message me personally. I know that there's some people when they're answering questions or when they want to ask something, they don't want to ask everybody. If you want to, you can send it to the whole group. Oh, I do not have an option for a chat with everyone, only the organizer. Okay, Cindy, well, I'm your friend, so I'll see your messages. So there you go. That's what you can do. Okay, so first things first, APIC Release. So APIC released a white paper called Between a Rock and a Hard Place. So for those of you who may not have heard about it, just please try to set some time aside to go through this when you have some time. So let's read a little bit about what this paper is about. So Recommendations for Balancing Patient Safety and Pandemic Response explores the lessons infection preventionists have learned during their fight against COVID-19. Written by APIC's COVID-19 task force, this paper highlights actions that must be taken at the healthcare facility level to strengthen infection prevention and control programs nationwide, and at the government level to make sure our nation has the infection prevention capacity to handle future pandemics. The authors of this paper make the case for investment in the infection prevention and control infrastructure in our nation's healthcare facilities so that basic infection control practices can be hardwired into processes of care. Building stronger infection prevention programs throughout healthcare will not only prove our ability to protect the public during future pandemics, but will simultaneously improve patient safety. I know that, we have all been working really hard throughout this pandemic. Infection preventionists, people in public health, our epidemiologists, COVID contact tracers, literally so many people have now learned what epidemiology is about, public health. And so take some time to go through this paper this weekend or during the week. Just set some time aside to make sure that you review what our professional organization is putting out for its members and the rest of the United States to see, and the world. Okay, the Google Drive. So I had a couple people being like, I can't access the Google Drive on my work computer, and yes, that is the truth. You will not be able to access the Google Drive on a lot of your computers. So especially if you work with the government or if you work at a hospital, you're not going to be able to access the Google Drive. Just please make sure that you try to access it on a personal device. Maybe try your cell phone, your tablet, your laptop at home. So find a place where you can access it, because this is where all of the materials are going to be. Other questions that I've gotten is a lot of people asking me, where am I supposed to do the readings from? I'm not sure. You're assigning chapters. I don't know where to find them. Again, It's the APIC text. If you're at a hospital, if you're in public health, you may have access to this text through your agency, so through your hospitals like library, or through your Department of Health's educational resources. If you do not, this is something that you can discuss with your leadership, or it's something that you're going to have to purchase. I'm telling you, it's impossible to prepare for this test. But you know what? If I say that, there's probably somebody out there who's like, no, you can definitely do this test without the APIC text. I'm telling you from personal experience, there is no way I would have passed my exam without this APIC text. This year is my recertification year. So 2022 is my recertification year. I've been trying to decide whether I am going to retest or if I'm going to try to do continuing education credits. The only reason I would retest, because this by far has been the most difficult certification I've ever taken, would be for you guys to make sure that I'm staying up to date with the content, their questions. So that's still a decision that I'm trying to make, but that's besides the point. Just make sure that you have access to this. Next thing, make sure you've got access to the study plan. You can access that on the Google Drive, where you can keep track of how you're doing, the tests that you're taking, the quizzes that you're taking, etc. So you guys all had an assignment to do this past week, right? So who actually took their practice 1 exam? You can say yes, you can say no into the chat. I just want to get an idea. Okay, lots of yeses, lots of yeses. Someone's taking it this weekend. Oh, somebody said they couldn't find it. So, okay, right here, you see this little certification guide down at the bottom right, the certification guide. You can purchase it through APIC, and it's all questions. It's all question-based, but it's excellent. It's an excellent tool. You need these 2 to pass the test. If you didn't want to join our study group sessions, you don't have to. If you've got these 2 resources and you're a visual learner, you really don't need the auditory instruction. These 2 things right here are what you need to do really well on the exam. And of course, knowing your CDC guidelines, but these 2 things right here are what you need. So that's where you could have found it. So the purpose of the Practice 1 exam is to let you know what categories of your examination content outline you need to focus on. So each question is attributed to a specific chapter or guideline or concept, right? That APIC wants to make sure that you understand working in infection prevention. So this Practice 1 exam tested you on all of these different areas: cleaning, sterilization, disinfection, environment of care, education and research, management and communication, employee and occupational health, preventing and controlling the transmission of infectious agents, surveillance and epidemiologic investigation, and identification of infectious disease processes. So go ahead and put into the chat which was the section that you performed the worst in. If there were 2, you can put 2. Just curious to see what our deficit areas are. Okay, so we've got lots of different things coming in. Surveillance and epi, okay. Cleaning, sterilization, and disinfection. Me too, me too. Cleaning, disinfection, and sterilization took me for a ride back in 2016. Let me tell you what, sorry, 2017, that's when I took my test. Education and research, yes. Environment of care, okay. Management and communication. Okay, so we've got a lot of different areas where people didn't score particularly well on, and that's okay. Listen, when I first took my Practice 1 exam back in the day, a couple years ago, I got a 58. I got a 58, and I was like, oh my goodness, the struggle is real. Like, I've got a long way to go. There's a lot that I need to learn. But that is part of preparing for the test. It's okay to not score so well when you are starting out your studying and you're figuring out what areas you're not doing so well in and what you need to pick up on. This Practice 1 exam should be your little blueprint for the next 3 months or 6 months or however many months you're planning on studying, to let you know, okay, hey, Luce, you actually missed a lot of concepts from chapter 13, which is statistics. You missed a lot of concepts from, you know, chapter 23, the immunocompromised host. Maybe you should read that again. There are concepts that you're missing. It should be a blueprint for what you need to focus on and what you should spend extra time studying. What score should we expect on the first time? Honestly, I wouldn't really set an expectation for myself. I'm not seeing anyone's responses. I think many of us can only send messages to you directly. Yes, that's okay. That is fine. I can see your messages. So what score should we expect on the first time? Don't set any expectations. This is just to get a baseline of where you are, what you need to do to improve, what areas you need to focus on. So like I said, the first time I took the test, I got a 58. What score should you be aiming for on the practice exams to pass the real exams? I have always said you need to aim for a 75. You need to aim for a 75. As long as you're doing good, 75 and above, you should be okay on the real life test. That's what I've always said, 75. Okay, so we are diving into the examination content outline. We're starting with identification of infectious disease processes, which is this very first part. So you can see that the bulk of your exam is going to come from this section up here, right? Identification of infectious disease processes, surveillance and epidemiologic investigation, preventing and controlling the transmission of infectious agents. So we're starting with that. This was your assigned readings, chapters 21, 22, and 23. So risk factors facilitating the transmission of infectious agents, microbial pathogenicity and host response, and the immunocompromised host. So let's go ahead and let's start with chapter 21, risk factors facilitating the transmission of infectious agents. Is 75% the percentage we should aim for? Yes. If you're going to be taking your test soon, that's what you should be aiming to get in your practice exams. If you're just starting your studying, don't set a specific, goal for where you need to be at. You're just starting your studying journey. All right, so chain of infection. This is the honest to goodness bread and butter of our entire profession, right? So infection prevention in its essence is you trying to minimize risk, trying to have the safest environment and processes in place possible for patient safety, right? Keeping our patients safe, keeping our staff safe. And how do we do that when it comes to infectious diseases? We have to focus on the chain of infection and what we need to do to break that chain of infection. So in this chain of infection, you've got your infectious agents, your reservoirs, your portal of exit, mode of transmission, your portal of entry, and then your susceptible host. Each one of these little thunderbolts, and you'll see when we go to the next slide, is going to represent different ways that you can break that chain of infection. And this is a graphic that's provided by APIC. So you can find APIC's chain of infection, like you Google APIC chain of infection, and this will be the image that it shows you. Okay, so with a susceptible host, we've got any person, especially those receiving healthcare. So susceptible host, we're trying to see what type of pathogen can, find its way to cause an infection in this host. How do we break the chain when it comes to susceptible hosts? Immunizations, right? So immunizations, treatment of underlying disease. So this is all, so each little bullet point is a much bigger concept in IP, right? So when it comes to immunizations, you've got to know about your schedules. You've got to know about the different types of vaccines that are administered, right? You've got inactivated vaccines. You've got live attenuated vaccines. So within each of these little check marks, there's a deeper amount of knowledge that you need to have in order to be able to understand how to break that chain of infection. Treatment of underlying disease, right? Diabetes, making sure that we're managing patients who have diabetes well, chronic kidney disease, lots of different issues that you can be managing to prevent infections in patients. So specifically thinking about surgical patients, pre-optimization before surgery, making sure that all of their labs are being drawn, that you're taking a look at. There's a multitude of things that you can look at. So just remember this, having access to health insurance so that people can actually be checking up with a doctor continuously for their appointments, for things that are going on, and patient education. So one of the biggest issues that we find in healthcare, you know, even like after a surgery, after a serious procedure, after a serious hospitalization, is patient education. So patients being educated properly on what meds they're supposed to take, their medication lists. If you don't do a good job, you know, educating your patients before they go and you're doing your discharge instructions, they may end up taking too much of a certain medication or stopping another medication. How many times have you seen patients who are showing up at our hospital because of issues with their meds? Okay, so breaking the chain with every single little check mark, there's a much deeper level of understanding that needs to be in place. So with the infectious agents, you've got bacteria, fungi, viruses, and parasites. So we will dive a little bit more into our friends, into our infectious agent friends when we move on to some of our microbiology chapters and really start to understand the different, you know, characteristics that bacteria and fungi and viruses and parasites have. But this is one of the funnest parts of the job, right? The challenge of knowing about bacteria, the different types of bacteria, which type of bacteria is more likely to be associated with this type of infection. What type of bacteria do we commonly find on skin? What type of bacteria do we commonly find in the GI tract? What type of do you get what I mean? Like you really get to dive deep into communicable diseases, and it's a lot of fun. It's one of, there's so many things I love about my job. It's difficult to really put a favorite. I think my favorite thing is that I get to learn every single day and that I'm challenged every single day. But yes, knowing your infectious agents, important. So breaking the chain, diagnosis and treatment, ensuring that we're diagnosing, treating our patients. Antimicrobial stewardship is a big piece, right? So many of us are participating in antimicrobial stewardship committees within our hospital where we're assessing, hey, can we de-escalate our antibiotics? Can we go from IV to PL? We receive the susceptibilities back on this culture. It's actually susceptible to, you know, a more narrow antibiotic rather than this broad spectrum that we're using. Can we go ahead and, you know, try to de-escalate some of these antibiotics that we're using? So breaking that chain. With our reservoirs, dirty surfaces and equipment, people, water. I'm a big fan of water in the sense of biofilms, outbreaks associated with sinks, water. Listen, if I could do a PhD, it would be more than likely on biofilms within intravascular devices, you know, like central lines. So if anybody knows out there a program or somebody who's studying this, let me know, because that would be one of the things that I would for sure do. Animals and insects, soil and earth. So breaking the chain, cleaning, disinfection, and sterilization. And even just this little check mark alone, there's multiple chapters in this APIC text covering cleaning, disinfection, and sterilization. There's multiple chapters. There's different guidelines. There's environment of care guidelines. There's guidelines on how you should be reprocessing devices. You've got, you know, your Spalding classifications for your non-critical, semi-critical, critical devices. I mean, it's like an iceberg, right? You're just touching on the very top of the entire thing. It's so much information. Infection prevention policies and pest control. Okay, so for the bottom of our chain, we've got our portal of entry. So actually, let's go this way. We've got our portal of exit, such as open wounds, skin, splatter of body fluids, and aerosols. So breaking the chain, hand hygiene, personal protective equipment, control of aerosols and splatters, respiratory etiquette, and waste disposal. All of these bullet points are things that have been really important during this pandemic, ensuring that our staff are adhering to hand hygiene so that they're able to prevent serious, you know, infections from them acquiring it themselves, and also from passing it on to patients. Personal protective equipment. You know, at the start of this pandemic, there was a point in time, I cannot believe it's been 2 years. There was a point in time where we had all of our N95s in our CEO's office, right? And this was, I'm talking like April of 2020. it was just wild. But so personal protective equipment is really important, ensuring that our staff know what standard precautions are, that they have access to personal protective equipment so that they're able to use it properly. We have now an entire aerosol generating procedure policy, which was not in place before this pandemic. So controlling aerosols and splatters, extremely important, respiratory etiquette and waste disposal. For breaking the chain for their mode of transmission. This is a big portion of your test, modes of transmission. So in this exam, they're going to assess, do you know the different types of pathogens that are common in healthcare? And do you know how they're transmitted? And what we can do to prevent the transmission of these diseases? That is going to be at the core of so many of the different questions that they ask you, whether they're asking you about, hey, this person is presenting with this clinical presentation, this is what their x-ray looks like, should we isolate them? We had a question like that last week. Should we isolate this patient for, TB, or why would this provider not suspect that it's tuberculosis? And it gives you different options, and all of that is assessing, do you know your pathogens? Do you know how they are transmitted and how you can prevent them from being transmitted? That's a huge bulk of the test. So you have to make sure that you're very familiar with the different infectious diseases that are frequently seen in healthcare facility. So modes of transmission, you've got contact, which is direct or indirect, ingestion and inhalation. So how do we break the chain? Again, hand hygiene, PPE, food safety, cleaning, disinfection, and sterilization, and isolation. And lastly, portal of entry, broken skin, incisions, the respiratory tract, mucous membranes, catheters and tubes, lots of different ways that bacteria and other pathogens are able to get into a susceptible host. How can we do that? Hand hygiene, personal protective equipment. Personal hygiene is also very important. First aid, and then removal of catheters and tubes when they're no longer indicated. So really trying to discontinue those central lines as quickly as possible, those indwelling urinary catheters as quickly as possible. As soon as they're no longer clinically indicated, let's try to get those devices out so that we can reduce the risk for our patients in our hospitals. Okay, so let's go over some key vocabulary. So what I'm going to need you to do is we're going to do virulence first. So I'm going to give you just a little bit of time so that you can take a look at the options that you have here. So you've got virulence, infectivity, pathogenicity, duration of exposure, and size of inoculum. So for virulence, what would be the matching definition? Getting lots of answers. Okay. Good job. Lots of B's. Lots of B's. So virulence, the ability to grow and multiply. Infectivity. Infectivity. There's going to be two popular answers. I can just already see it. And I was correct. So the two popular answers that I'm getting right now are D and E. That's the majority of what I'm seeing in the chat. And the correct answer is D, the ability to enter tissue. All right, pathogenicity. We're narrowing things down here. Very good. E, the ability to cause disease. Duration of exposure. Very good. Yes, the length of time the person is exposed to the organism. And then the size of inoculum is going to be C, the number of organisms needed to cause disease. So all of this key vocabulary is really important to know because they may be using it when they ask you questions, and it's applicable to all of the different infectious diseases that you're going to be learning about and studying while preparing for this test. And even as an infection preventionist, right? So duration of exposure, we know that the duration for exposure for TB, it's got to be prolonged exposure, right? So it's important to know what our definitions are and what they're referring to, because it's going to really help you in determining what your answers should be. I'm gonna need to pick up the speed here because it is 2:28. I need to get my life together. All right, so medical interventions that increase risk. Presence of invasive devices, placement in an intensive care unit, and we know why. ICUs are the place where our most critical patients are. That's where you're going to have patients that are ventilated, who have central lines, who have indwelling urinary catheters, chest tubes, drains. I mean, you name it, they've got it. Flexoseals, you've got it's you know, it's the perfect environment for organisms to find their way into a susceptible host who's already critically ill, may have had an accident, has had some sort of, health issue that has put them in that condition. Exposure to antibiotics or certain medications, absolutely 100%. Immunosuppressive therapy, yes. Length of hospitalization. So how long you're in the hospital. If you're here for just a day or two, that's not so bad, not so bad. But we've had patients who have been here for months. I don't know if I've had a patient that's been here for years, but months for sure. Months for sure. Staffing ratios. Can we talk about that nightmare, right? So when your staffing's out of whack, it impacts the safety of our healthcare workers and our patients. I'm not gonna, you know what, let me not even stir the pot because I've got some very strong feelings about some stuff that's going on right now politically when it comes to nursing. So I'm not gonna do it, but I'm just saying, how about we talk about staffing ratios? People in Congress, how about that? Experience and training of care providers for certain device-associated infections, and the increased number of healthcare personnel examinations and procedures. All right, what are some patient factors that increase the risk of transmission of infectious agents? Immunosuppressive diseases and disorders, malignant disorders, our patients' APIC scores, so their acute physiology and chronic health evaluation score. If they've got a poor nutritional status, their age, diabetes, pregnancy, travel history, their occupation, residence, contact with certain pets or animals, for sure, yes. Different pets have different risks, right? Cats. What do we think of when we think about cats? And pregnant women. Rapid fire, let's go. Yes, yes, yes. Toxoplasmosis, yes. 10 out of 10. Extensive burn wounds, trauma. Okay, so sites of infection. This is just a quick picture, right? With all of, remember when we were talking about pathogens and then their transmission? It's important to be familiar with what different types of diseases are associated with what conditions, right? So bacterial meningitis, Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenzae, Streptococcus agalactiae, Listeria monocytogenes. With skin infections, Staph aureus, Streptococcus pyogenes, Pseudomonas aeruginosa. Pseudomonas aeruginosa is my favorite bacteria, just in case you guys didn't know. She's a baddie, okay? She's literally out here ruining everyone's days, and it's very dangerous. That's not particularly why she's my favorite, but it's just because my first big outbreak in the field of public health was with Pseudomonas aeruginosa. So, first love. The next one is sexually transmitted diseases. So chlamydia, Neisseria gonorrhea, Treponema pallidum. And all of this stuff is important, right? When you're an IP, Linda, that is foul. She says it smells good in the lab. I cannot. Okay. Okay, back to this. Let's bring it back, everybody. So with sexually transmitted diseases. So if you're an infection preventionist and you are, people want to know what it smells like. I cannot. They say, why does it smell like, Linda? I don't know. Okay, let's see what she says. It smells like grapes. Like grapes? Okay, you know what? And this is exactly what I'm talking about in life. We get to learn new things every day. Now we know that Pseudomonas aeruginosa smells like grapes at the lab, and some of our bedside nurses are saying that it does not smell good at the bedside. So there we go. But okay, so when you're reviewing labs, right, as an infection preventionist, you've got all of these labs that you need to review, all of these things that you need to know. Knowing the names for these different organisms is really important. So if you see something come up that says Treponema pallidum and you've never seen this organism before, hey, we need to know this. We need to know Treponema pallidum is what? What is Treponema pallidum? What is that referring to? Yes, syphilis. Excellent, excellent. So we won't go through all of these, but important to know that with every different type of, body system, you can have all different sorts of infections, okay? All right, so infection risk reduction, adherence to appropriate infection prevention measures, really important. So hand hygiene, personal protective equipment, thorough cleaning of both high-touch surfaces and the routine environment is extremely important. Surveillance activities. SSIs are reduced when surgeon-specific healthcare-associated SSI rates are provided to the surgeon. The UTI rate is decreased when the unit-specific healthcare-associated CAUTI rates are provided to specific nursing units. So surveillance activities are a huge part of what we do in infection prevention. Now, specifically relating to adherence to appropriate infection prevention measures, this bullet point up here, one of my favorite podcasts that I've ever heard and ever listened to is called The Best Case Ever, 61 Biohazard Preparedness, the Protected Code Blue. And this was an amazing podcast. A doctor from Canada spoke about the SARS pandemic and how when they started to receive SARS patients in their emergency department, she explained the chaos of trying to, run a code blue patients who are, in acute respiratory failure, trying to intubate. She called it the PPE double, like where you were wearing double everything, double gloves, double masks, double N95s, double everything, right? And how difficult it was to ensure that you were adhering to proper precautions. So I really encourage you to listen to this podcast when you have time, especially for my auditory learners. There's gonna be a lot of different ways for you to get access to this information and to learn about infection prevention. There's lots of podcasts, lots of YouTube lectures. So I'm gonna go ahead and send this link to everyone. But yeah, take a listen. It's excellent. It's an excellent podcast. And here, another great resource is this infection prevention education course through Coursera. But this is specifically showing you, how much we've talked so much about isolation precautions and PPE and what kind of PPE we should wear and distance of droplets and how far they can travel. So large droplets, small droplets, and droplet nuclei. This is a really great image to show what that looks like. And it's a great course, personally, for those of you who are newer to infection prevention, or even if you have been in infection prevention for a while. They have this entire soap opera called Gloves and Gowns, and it is fabulous. It's excellent. So I recommend you check it out. With personnel practices, immunization of personnel must be required and available. That's why we have such, stringent onboarding processes through HR. They may even draw your titers to see what your what your immunity looks like in your immunization history. Restriction of healthcare personnel with a communicable disease or infectious process, such as diarrhea, group A streptococcal infections, conjunctivitis, draining dermatitis, or exudative lesions, active tuberculosis, and possible infectious rashes. And then assignment of patients to be cared for by immune healthcare personnel. And 4, protocols should be created for evaluation and follow-up of employee exposures to infectious diseases. Oh my goodness, yes. Employee health and exposures were a lot of what we've had to do over the past couple of months. So definitely a lot more familiar with the employee health portion of this exam after all that we've been through, right? Okay, so true or false? Patient with the same airborne disease may share a room if there is no clinical contraindication. Patients with the same airborne disease may share a room if there is no clinical contraindication. Okay, getting lots of answers. What do you guys think in the room? Oh, sorry, I've got my team here. All right, true. All right, next one. Cohorting of patients infected or colonized by a common organism by room or personnel assignments can reduce the risk of transmission of infectious agents to other non-infectious patients. What do we think? Very good, very good. Correct. Again, think about I remember when the pandemic was first getting started and we were having all of our, our executive meetings, and we were talking about cohorting and creating our COVID isolation units and hot zones and green zones. But yeah, cohorting of patients is a great strategy to reduce the risk of transmission. Increased HAI rates have been associated with the use of non-permanent staff. Is that true? What do you think, Hamilton? For sure, right? Yeah. Yes. Yes, this is true, right? This is most definitely true. So increased HAI rates have been associated with the use of non-permanent staff. When you've got non-permanent staff that are not familiar with your processes, with your procedures, your culture, the way that things are quote unquote done, it can make it very difficult to ensure that that everyone's following all of the proper procedures, because there's that lack of buy-in, there's that lack of knowledge, because they may not be, at all of the different educational opportunities that our permanent staff, have and get, meetings, etc. And we've seen this in the pandemic. Yeah, we sure have. We most definitely have. All right, so practice exam 1, this is one of the questions. So the IP wants to calculate the surgeon-specific rate of infections associated with spinal fusion surgeries in the facility. Which one of the following data elements will he need? Number 1, number of spinal fusion procedures within the designated time frame. 2, number of spinal fusion SSIs within the designated time frame. Number 3, number of spinal fusion surgeries performed by each surgeon within the designated time frame. Number 4, number of spinal fusions for each surgeon within the designated time frame. So what is your answer choice? Okay, we've got lots of different answers. We've got, I think, almost every answer chosen, except I haven't seen a B. So we've got, the top choices were A, C, and D. Now, is there a top one? It's kind of hard. I feel like it's split pretty evenly between the A's and the D's. All right, guys. The correct answer is D, 3 and 4, all right? We need to divide the number of spinal fusion infections for each surgeon by the number of spinal fusion surgeries performed by each surgeon. Why? Because we're looking for surgeon-specific rate, right? It's a surgeon-specific rate of infections. All right. Let's jump into chapters 22, microbial pathogenicity and host response. Okay, so colonization. Let's talk about colonization. This occurs when microorganisms inhabit a specific body site, like the skin, but don't cause signs and symptoms. So what are the differences between signs and symptoms? Who can tell me what would be the difference between a sign? What's a sign? Yes, objective versus subjective. Very good. Symptoms are subjective. Signs are objective. Very good. So a sign would be like a fever. Great, great. Symptoms would be like pain, something that, the patient is telling you that they're feeling, but you're not able to find a way to quantify it and measure it. All right, infection. So clinical signs of illness or inflammation. So for example, localized pain or tenderness, redness, warmth, swelling, pus, fever due to tissue damage caused by microorganisms invasion. And this is what it looks like. So knowing the difference between colonization and infection is really important, especially when you're trying to, talk to patients and explain whatever's going on with them. So with colonization, you see that we've got our exposure. There's, there may be invasion and there may be colonization, but we don't have that toxicity, that tissue damage, that breakdown in our skin, these signs of, inflammation, redness, erythema, all of that isn't going on. A perfect example is if you've ever had the pleasure of working with the health department on different types of investigations. I know when I was at DOH, I worked with a lot of different facilities on investigations, whether it was because of mechanisms of resistance like OXA48, VIM, IMP, NDM, etc., or Candida auris, right? If they identify cases of Candida auris, for example, at a long-term care facility, they're going to do a point prevalence survey. And that point prevalence survey means that there's going to be multiple people in either a wing or a facility that will have to be swabbed. Their axilla, their inguinal area for their groin for C. auris. So trying to explain to a patient, hey, we're doing this investigation. You could potentially be colonized with this organism, trying to explain to them the difference between colonization and infection. The thing is, right, that with colonization, things can start out friendly, but then it can turn into an infection. So you have to be very careful. That's why we have decolonization strategies for MRSA, right? Before you go in for surgery, povidone iodine in the nose or the nose in or whatever other, product you're using for your decolonization. This is why we do it. Euparacin, yep. So principles of microbial pathogenicity. What is the measure of a microbe's ability to invade and create disease in a host, and is determined by characteristics that relate to the favored site of invasion, disease induction, and avoidance of host resistance? What word am I looking for? Very good. Very good. Virulence. Good job. Initial element in virulence. Oh, I gave it right there. Look at me. I even gave you a hint. Initial element in virulence, the ability of an organism to survive in the external environment during transit between hosts. The second element is the mechanism for transmission to a new host. So survival times of pathogens. Listen, this is one of my favorite slides to go over with my nursing teams. It is so much fun to put up the slide and not have the times showing. And then you're like, guys, how long do you think C. diff can live in the environment in a non-porous surface? And I'm telling you, people will confidently be like, 72 hours. Look at me right in my eyeballs and tell me 72 hours, 48 hours, 7 days. And it's, it's so much fun to be able to educate and tell them like, no, these spores are out here trying everybody's lives, okay? They did not come to play. They're aggressive and they're here to stay. So it's really exciting to be able to tell them, no guys, like Staph aureus can live on the environment for 7 days to greater than 12 months. And that's why I tell them the importance of when they get to their workstation, making sure that they're wiping all of their equipment down, their keyboards, their mouse, taking care of the environment. I like to talk to them about norovirus because we live in Florida. So there's lots of, cruise ships that leave from Tampa Bay and other areas here in the entire state. So I like to tell them, look at how long norovirus can live on the environment for. This is why some cruise ships have a hard time managing outbreaks of norovirus, as well as our long-term care facilities, because norovirus is a very, very sneaky virus that can live on the surface of all different types of things, doorknobs, tables, utensils, spoons, for quite a long time, and it has a very low infectious dose. All right, so exotoxins versus endotoxins. So let's talk about our differences between exotoxins and endotoxins. So exotoxins are proteins produced inside pathogenic bacteria, most commonly gram-positive bacteria. Okay, our gram-positive bacteria, what color? What color would we see them when we do a gram stain? Just question. Yes, 10 out of 10, 10 out of 10. Love the energy. Purple, the room here is going wild. Just kidding, but they're whispering. They're whispering the answers to me. They're whispering the answers to me. Purple, blue, yes, very good. Okay, let's get back to this. The exotoxins are then secreted or released into the surrounding medium following lysis. Endotoxins are the lipid portions of lipopolysaccharides, or LPS, that are part of the outer membrane of the cell wall of gram-negative bacteria, like lipid A. The endotoxins are liberated when the bacteria die and the cell wall breaks apart. Very important to know the definition and the difference between exotoxins and endotoxins, because you may have questions on it. So you've got exotoxins, some species of both gram-positive and gram-negative bacteria. Proteins are secreted from the cell, high toxicity, heat liable. If you're thinking cholera, tetanus, and botulism. With endotoxin, you're thinking of most gram-negative bacteria and listeria. So it's part of that cell, the lipopolysaccharide that fragments off. You're thinking low toxicity and meningococcemia and sepsis. All right, so the cellular immune system, cell-mediated immune system, it's induced, mediated, or regulated by T lymphocytes and mononuclear phagocytes. Let me tell you something, immunology has to be by far one of my favorite classes because it's chaos, right? Immunology is chaos. Like, let's be serious. When you start looking at pathways of activation and you've got interleukin, you know, the interleukin does this, and then homegirl on the, you know, on the other side, it kicks this thing off. It's wild, okay? Immunology is wild. It is one of my favorite classes that I took in graduate school. If you haven't taken an immunology class, highly recommend it. It is a 10 out of 10. And so you've got your cell-mediated immune system in your humoral immune system. So humoral immune system is antibody-mediated, which gains the ability to recognize virus-infected cells and adhere to and kill them. So you're talking about your CD4, your CD8, so your cytotoxic or suppressive cells, and your B cells. Also known as innate immune system and adaptive immune system. So innate because it's natural, adaptive, I mean, you know, because it adapts as you encounter different types of pathogens, you're going to develop immunity to them. And then cytokines. How much have we talked about cytokine storm or a cytokine storm during this COVID pandemic, right? Cytokine storms. Yes, 1000%. These are substances that have specific structures and biological activities which can make your immune system essentially short circuit and go haywire. It's really wild. It's very exciting. We need to have a whole lecture on the immune system. That's what we need to do. I'm gonna put it on my list. So antibodies are produced by B lymphocytes. So components and functions of the humoral immune system. So let's talk about our immunoglobulins. I have some very strong feelings about immunoglobulins, okay? I'm not really gonna get into all of it right now, all right? Just know that I call IgM the Beyonce of the immunoglobulin crew because she rings the alarm, right? IgM rings the alarm. So that's all I'm gonna say for now. Let's go ahead and let's do our matches. Okay, so number one, IgM. Which one are you gonna line this one up with? IgM. I'm getting answers. The answers are coming in fast. Yeah, we're gonna have to go quick, guys, because our time is almost up. We might go over by a little bit today. So because you know there's a lot of things we need to talk about. But IgM, yes, early immune recognition and response. So that's why I called IgM the Beyonce of the immune system. She's got this video. She's got this song. Okay, do you guys remember "Ring the Alarm"? The music video by Beyonce, "Ring the Alarm." Ring the alarm. Do you guys remember that? Yes. So it's the first one that's running around town that's like, hey, everybody, listen, get it together, okay? We're under attack. I need you to pack your bags, get your stuff. We gotta go. We gotta go to work. Everybody get it together. So IgM, Beyonce, please remember her. Queen. Love IgM with its 5 little arms. Okay, next one, IgD. E, functions in later immune response. Let me tell you something. Am I a big fan of IgD? I mean, I think I just haven't gotten to know her well enough personally, because it's not one that comes up very often, but it's good for you to know. Okay, IgG. IgG. You see these in your labs all of the time. They pop up on your APIC or Cerner all of the time. This provider ordered an IgG for this, or whatever. There's so many things you can order IgGs for. Yes, late occurring immunoglobulin and immune response, and it is the longest lived. So it's showing you, hey, I have a history of this. I recognized you. It's your wanted poster, right? It's the one that's able to put up the wanted signs when that organism comes back into your immune system. IgE. IgE. Very good. Principal allergy inducing immunoglobulin. And then IgA. Love IgA. Love IgA. Excellent. 10 out of 10 for effort. It's effective in preventing virus infections of the respiratory tract and intestinal mucosa. I remember one of my favorite lectures in grad school was all about IgA. And my professor, my MPH was in global communicable diseases. And so he was really, really cool guy. And he was talking to us about soup de carotte, which is in French, like literally carrot soup that they would give to patients to try to boost their IgA immune response. Exciting times. All right, questions. Think fast. The most immediate post-operative surgical site infections beginning in less than 24 hours from incision are caused by A, Staph aureus, B, Streptococcus pneumoniae, C, Streptococcus pyogenes, or D, E. coli. Lots of different answers. Basically, A, B, and C have been selected. The correct answer is Streptococcus pyogenes. All right, number 2. What bacterial factor or structure facilitates bacteria implanting on plastic devices? A, cell wall, B, exotoxins, C, endotoxins, or D, the glycocalyx? Okay, lots of answers, but I do have a lot of D's, which is our glycocalyx. It's that sticky slime layer that allows for, you know, all sorts of different fun friends to adhere to our devices. Which immune marker represents past exposure to disease? Which immune marker represents past exposure to disease? All right, very good. D. IgG, got it. IgM, meeting it. Yes, I like that. There's so many ways people remember things. I love it. IgG, got it. IgM, meeting it. Yes, good. All right, chapter 23, the immunocompromised host. Gonna try to go through this quickly because we're almost out of time. Okay, so there's some key concepts when it comes to our immunocompromised hosts. There are several categories of immunocompromise exist, and some patients may have more than one type. So we know this. There's complex patients. Through history taking and detailed physical examination, there's often a reveal of potential problems. Host resistance to infection can often be augmented, which is a good thing. Avoidance of hospitalization is desirable whenever feasible because we've got lots of different things in our hospitals that can really, really affect our immunocompromised patients. Consistent use of standard precautions, specifically hand hygiene and respiratory etiquette, as well as transmission-based precautions when indicated, is the most important of all interventions. And I think that says a lot. I think that says a lot about how important infection prevention is, and not just the roles that we do with surveillance and auditing, but for our frontline staff and our bedside teams to ensure that they are adhering to. I think sometimes infection prevention gets a little bit of a reputation because we have we have to do a difficult job. We have to assess a lot of processes. We have to do a lot of audits. There's a lot of rounding. There's a lot of times when we're providing feedback to staff that they may not be too excited to hear, right? If we're having to tell someone, hey, your dressing doesn't look too good. Some people may internalize that, but it's really important that our staff see the importance of infection prevention, because at the end of the day, most of us on this call and the people working in our hospitals join this field to help people, right? To take care of people, to make a difference in the world with the time that we've been given. And so ensuring that our staff understand the importance of infection prevention and that they're adhering to those simple things, hand hygiene, respiratory etiquette, and transmission-based precautions is really important. Okay, can someone tell me an example of an NHSN classification of an immunocompromised patient? When you're trying to determine if a patient meets for an immunocompromised status by NHSN criteria. All right, so I've got neutropenic. I'm reading the answers I'm getting. Less than a 500 white blood cell count, chemotherapy, previous transplant, malnutrition, recent bone marrow transplant, stem cell transplant. Okay, another stem cell transplant. No spleen. Splenectomy, yes. That was good. Okay, so immunocompromised patients include only those with neutropenia, defined as an absolute neutrophil count or total white blood cell count of less than 500. Those with leukemia, lymphoma, or who are HIV positive with a CD4 count less than 200. Those who have undergone splenectomy. Those who have a history of solid organ or hematopoietic stem cell transplant. Those on cytotoxic chemotherapy. Very good, you guys got a lot of these. Those on enteral or parenteral administered steroids, and this includes inhaled and topical steroids, daily for greater than 14 days on the date of event. Okay, so this is our NHSN definition. So let's talk about comprehensive management of the immunocompromised host. There's the recognitions of the categories of host defects that are associated with impaired resistance, knowledge of the type of infection to anticipate in each category of immunocompromise, and they have entire charts. I'll just briefly go into some of the charts, but this chapter is excellent. It's an excellent chapter. The most common portals of entry for opportunistic organisms, which are going to be our skin, the lungs, gastrointestinal tract, oropharynx. The fact that clinical manifestations of illness may be different in the immunocompromised host, and an understanding of the broad array of modalities for prevention of infection. We're not going to do this one. Net states of immunosuppression. They talk about this in the chapter, but it's basically going into all of the different, things that you need to take into account to determine what that net state of immunosuppression is for each patient. So some categories of host defect that are associated with impaired resistance. So defects in the cutaneous barrier to invasion of endogenous or acquired organisms. So you've got surgical incisions, thermal or chemical burns, traumatic injuries to the skin, severe dermatologic conditions like poorly controlled eczema or psoriasis, scleroderma, mycosis fungoides, chronic fungal infections of the skin or nail beds, indwelling intravenous lines, either temporary, right, like some of our central lines, or long-term, like you can have a port for a very long time, tunneled lines, right? They're for longer periods of time. Injections, so either legal, medicinal, or illicit. All of the injections, all of the above can put you, in a predicament. Ulcers, decubitus, diabetic vascular insufficiency, and others. You've got an entire list of mucous membrane barrier defects. They're basically telling you these are the different kinds of things that you need to think about when you have an impairment in either your skin or your mucous membrane. If you've got a dysfunction of your cell-mediated immunity, so some of the bacteria, it's going to be primarily intracellular pathogens like Listeria monocytogenes, Salmonella species, Mycobacterium, including Mycobacterium tuberculosis, nocardia. We had a question on nocardia last week. Legionella pneumophila, Rhodocus species, and Pseudomonas pseudomallii. this keeps going, right? So the most common opportunistic infections associated with specific immune deficits. So we talked about what can put you at an increased risk when you're an immunocompromised host, like surgical incisions, all of these different things. Now, what opportunistic pathogens are associated with those things? Breaks in the cutaneous integrity, Staph aureus, or coagulus negative species of staph, like Staph epidermidis, Staph hominis, Streptococcus pyogenes, Corynebacteriums, defects in your mucous membranes, anaerobic bacteria like Bacteroides fragilis, Clostridium perfringens, Candida species, Enterococcus species, lots of different things. So what are our most important portals of entry? It's going to be the skin, and you can pause when you see the recording so you can read more about this. Oropharynx, the lungs, you may just have one lung, but the lungs, and the gastrointestinal tract. So in the neutropenic host, the gastrointestinal tract is the most important source for bacteremia as the result of transmigration across the mucosal barrier. Another thing, while I was reading this chapter and they were talking about lungs, this is important, so I'm going to read this. Within the gastrointestinal tract, due to decreased acid production, use of enteral feeding, and stress ulcer prophylaxis, the stomach becomes colonized with bacteria, particularly gram-negatives. The contribution of this site as a potential source of healthcare-associated pneumonia continues to be a topic of debate, with studies demonstrating from no role to up to 15% of patients with pneumonia having the stomach as the source of pneumonia. All right. So clinical manifestations of disease may be different in the immunocompromised host. So another game of matching, and then we'll do some questions and we'll be done. Sorry that we're going over today. If you need to hop off, you absolutely can. Okay, so patients who are sedated or have a central nervous system dysfunction, neutropenic patients, elderly patients, and patients receiving corticosteroids. So you've got lots of different options here. Try to match them up as best as you can with A, B, C, or D. So number one, patients who are sedated or have central nervous system dysfunction. Perceive pain less well and are less able to articulate a problem to the examiner, right? Because they're sedated, they're not able to communicate as well or at all with our staff. All right, neutropenic patients. Neutropenic patients. Neutropenic patients. Very good, lots of A's. Have little purulence at the site of infection and less obvious chest radiograph findings. Elderly patients. Elderly patients. Yep, may have confusion or incontinence as their only manifestation of infection. And patients receiving corticosteroids. Diminish or absent fever response. All right, we're getting into the questions, and then we've got 3 questions and then you're done. Question number 1, all the following are descriptions of patients with immunocompromised status except A, HIV with a CD4 count of less than 200, B, leukemia or lymphoma, C, neutropenia, and D, 1 year post bone marrow transplant. So all of the following are descriptions of patients with immunocompromised status. Very good. Very good. 1 year post bone marrow transplant. So all of these up here are examples of patients with an immunocompromised status. Neutropenia with an absolute neutrophil count of less than 500, leukemia or lymphoma, HIV with a CD4 count less than 200, splenectomy, early post-transplant, on cytotoxic chemotherapy, on high-dose steroid therapy. And APIC is very specific about what they're stating when it comes to steroid therapy. When we look back our NHSN definition, it just says those on enteral or parenteral administered steroids, excluding inhaled and topical steroids daily for greater than 14 days on the date of the event. So, you know, APIC dives in a little bit deeper. So why is it that 1 year post bone marrow transplant isn't included? So our rationale continued. Recipients of transplanted marrow or stem cells experience severe immunosuppression for several months after transplantation. This immunosuppression occurs regardless of the type of graft, the underlying disease, the condition and preparative regimens, and whether graft versus host disease develops. Even in the absence of graft versus host disease, reconstitution of a fully functioning immune system occurs slowly during the course of several months to years. Thus, interest is considerable in modalities to prevent infection during the period after transplantation. And when you're reading chapter 23, they do a good job of diving more. This is under the immunization section. They do a good job of telling you, if you've had a bone marrow transplant, we're looking at potentially starting to immunize you after 6 months, right? So recent bone marrow transplant, yes. But as far as 1 year post-transplant, that person may not qualify. It really depends, case by case basis. But even when we look at our list, it's not specifically stated on there. Because of the ongoing use of immunosuppressive medications, solid organ transplant recipients are at risk of life-threatening infections indefinitely, forever and ever. All right, question number 2. Patients with cell-mediated immunity dysfunction are susceptible to infections attributed to pathogenic intracellular bacteria. Examples of these organisms include, and we saw a lot of these in the chart that we went over. The charts are important. When you're studying, make sure you're taking a look at the charts that they have on there. The charts have a lot of very valuable information. All right, so it's either B or D. The majority of the group is saying B or D. The correct answer is B. As a host becomes progressively more immunocompromised, progressively fewer virulent organisms are able to become pathogenic. Thus, patients with major immune defects are subject to a larger number and greater variety of infectious diseases. The most common opportunistic bacterial infections associated with cell-mediated immunity dysfunction are primarily intracellular pathogens that include Listeria monocytogenes, Salmonella species, etc. We already went through this list, remember? Do these sound familiar? Important. Gotta know it, gotta know your charts. All right, question number 3. Which of the following are allowed in an intensive care unit or other unit with immunocompromised patients? A, latex-free balloons. B, flowers in a vase. C, fresh fruit. Or D, fish tank. Okay, so everyone is saying A, which is great. So what they're assessing here is, hey, do you know the risks of flowers in an immunocompromised host? Do you know about aspergillosis, right? Do you know about all the different types of waterborne pathogens that could be in that water and make their way over to your patient? Fresh fruit, same thing, gram-negative bacteria. Fish tanks, don't even get me started on fish tanks. I have nothing against the fish in this world and fish tanks. May they live happily out there in their tanks. But absolutely, absolutely not. No, ma'am. No fish tanks in immunocompromised areas. No. I can't even go into all of it because there's too much to go into for fish tanks. So here's your explanation. You can pause and read it. Okay, so assigned chapter readings for next week. Listen, next week is going to be a hot mess express. We have a lot of information to cover with microbiology basics, laboratory testing and diagnoses, and antimicrobial resistance. So it's a lot of reading, and these are really important chapters. These 3 chapters up here are extremely important. So please make sure that you're reading these because they are key to making sure that you do well on the test, especially for your identification of infectious disease processes. All right, do you guys have any questions before we wrap this up? Can you please share the Google link to the chat, please? Yes, I can. Again, guys, remember, I'm going to be posting the recording on YouTube. If you want to say hi to me on LinkedIn, that's great. But if you listen to the lecture today, you should remember that they're going to be on YouTube. Suja Matthew. Suja, Suja. Are you my house supervisor, Suja, or are you another Suja? Like, are you my house soup that's downstairs right now?
No.
Or at home?
I'm from Heinz.
Huh?
I'm from Heinz, VA.
From where?
Heinz, VA, Illinois.
You're in Illinois? You are not my house supervisor. Hey, Suja. Listen, I have a house supervisor here at Celebration who has your same name. That's why I was wondering. Welcome. Thank you for joining us today.
Thank you.
Okay, guys. Well, that's it. Oh, wait. I'm sorry. What?
I missed the last class. Is that also recorded in YouTube?
Yeah, you can find it on YouTube for sure.
Okay.
What is your YouTube channel to find this recording? Okay, you're going to type into YouTube, CIC Epidemiologist. And then you'll find my channel. I put it right there. Oh, wait. That went only to Anita. How do I send it to everybody? Oh, everyone right here. I'm going to type it. CIC Epidemiologist. Okay, guys. Well, thank you so much. I'm going to go ahead and stop the recording now, and I will see you guys next Friday. Bye-bye.